Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Laboratory Corporation of America.
Hello, everyone. My name is Chuck Vega. I'm a clinical professor of family medicine at the University of California, Irvine, where I also serve as assistant dean in our School of Medicine here. And welcome to this program entitled Informing Alzheimer's Referral, Blood-Based Biomarker Evaluation in Primary Care. A very exciting time in the care of folks with possible Alzheimer's disease. And I'm joined by an expert panel to help me with this important discussion. Dr. Ali Atri is the Chief Medical Officer in the Banner Research Alzheimer's and Research Institute in Arizona. He is also director of the Banner Sun Health Research Institute in Arizona and a lecturer on neurology in the Department of Neurology at Brigham and Women's Hospital and Harvard Medical School. Also joining me today is Dr. Michelle Milkey, who is chair and professor in the Department of Epidemiology and Prevention and at Wake Forest University School of Medicine in Winston-Salem, North Carolina. Welcome to you both.
Thanks, Chuck. Great to
Thank
be
you.
here.
All right. So with that, today we're going to talk about just how we might identify folks with cognitive dysfunction, starting with primary care, which is where most of these patients should be identified. And so that's going to be my portion. And we'll be talking about diagnostic evaluation together because I think that there are different stages and where those stages get completed, how they get completed is really important. And now we have this potential for using blood biomarkers. So actually looking at some of the pathogenesis of the disease, of Alzheimer's disease, that is detectable in the blood. And we'll talk about some of the benefits and potential limitations of that testing. And then finally, we'll be putting it all together and talk about how to actually apply it. So I'm up first as a PCP. So probably patients are going to be coming into my clinic first. Maybe they have some cognitive complaints. Maybe they don't have cognitive complaints. We really should be screening for folks 65 and over annually, at least for cognitive function. But one thing I think is really important to know for PCPs is that I think it is critically important that we identify Alzheimer's disease as early as possible for life planning, for maybe some amelioration of other factors that could be deleterious to patients' cognitive dysfunction, but also because we now have disease-modifying treatments that are available, and I'm sure we're going to get into those as we go through. Now, it can be hard to do that screening in a busy primary care practice. I realize that there are some very simple instruments that only take a few minutes to use, and that can be done as part of an annual wellness visit. One thing I do is I tend to follow my patients, and patients, I know they're premorbid functioning. So somebody who always made all their appointments for their complicated illnesses, took all their medicines on time, got their labs on time, etc. And now I see that falling off. I get concerned and I'm going to put them through a screening. Or I'm also taking care of a whole family. And if someone in that family or someone close to them reports, they're kind of slowing down and really forgetting a lot of things, repeating themselves a lot, that's another time that I'm going to recommend a screening test for cognition. Now, will I refer at that point? Generally not. I still want to, really own care at this point and try to do as much as I can for the patient. Look about for also for really simple, potentially reversible causes of cognitive dysfunction. We're using a medication that can interfere with cognition. You have uncontrolled mood disorders, be it depression or anxiety. You have significant hearing loss. All of these are identifiable and can be corrected, oftentimes with an improvement in cognitive function with a little bit of time. But there are many cases where I sit on the fence because the patient does have 12 or 13 chronic illnesses, plus they have this cognitive dysfunction now. So there could be multiple factors going on, and it seems like potentially mild cognitive impairment, but I'm not sure. And so now we have biomarkers, and we're going to go through those in a little bit more detail. But there's blood-based biomarkers, there's CSF-based biomarkers, and there's imaging-based biomarkers. All these can be really helpful to identify patients at an earlier stage when you really have, I think, more of a chance to modify their disease course. And so to set this up, we have a case which we'll run back through as we come, through this discussion. It's a 72-year-old woman in my practice, and she's been my patient for a long time. And it's exactly what I mentioned earlier. I noticed that she missed a couple appointments, maybe one with me, maybe one with a specialist or one of our clinical care team. She also isn't taking all our medications at the time. Oh gosh, I just keep forgetting that darn cholesterol medication. I bet that's why my cholesterol is high today. And this time, when she comes in, she actually has a family member with her, and that's not normal for her. And the family member says that they're concerned because she has been more forgetful, and she actually got lost on her way home from the store, and that's new. So now we have some relatively new guidelines for the diagnosis of Alzheimer's disease, and so maybe it's definitely a good time. Actually, it's always a good time to bring in Ali and Michelle. Maybe you have some comments about what I just described, that initial presentation, or how you might go about thinking, if you were that primary care, what would be the things you would look for, and how might you start in the screening process?
Yes, thanks, Chuck. I appreciate a nod to the CPG, the clinical practice guidelines, which really are supposed to empower patients and clinicians to work together in a patient-centered way. And the who really is a person who either self-reports changes, or a care partner or a clinician is wondering whether there are cognitive, behavioral, functional changes. So this is a multi-tiered process, really. Um, they're not diagnostic guidelines for Alzheimer's disease or Lewy body or PSP or vascular dementia. Those are, elsewhere, and they'll change. But this is sort of the elements of a high quality, patient centered process that can, lead to what we call a three-step formulation that's structured, personalized, and uses tiers of diagnostic testing and evaluation. So it's not a shotgun approach. And it puts it in one place for the first time. So not just for the subspecialty setting, like cognitive neurologist myself, but actually it's meant to be for primary care, specialty care, and subspecialty care. And each part of that really gives guidance about where to go next. Uh, and it's sort of predicated on practices of good medicine, including history taking, but it tells you all the different elements. And what it also does, there's a whole Alzheimer's and dementia journal edition devoted to this, with multiple executive summaries. It actually gives you lists of tables of here cognitive standardized cognitive assessment instruments, like whether it's the MoCA or something else, and the pros and cons and links to them, for example. For example, activity daily living. These are the instruments that you may consider. Here are the pros and cons. This is how long they take. Or if you're thinking of depression or neuropsychiatric or overall, these are the different instruments that could be used. And it really provides a kind of a rigorous evidence-based, practice-informed foundational steps to kind of capture that core elements of that high quality evaluation and disclosure process. And there are 19 recommendations, and they're formalized in figures that give you flowcharts, basically. But ultimately, as you listen to the patient, you go through a review of systems, you do a standardized, cognitive assessment instrument in the office. The three foundational steps are, you know, let's decide whether I can really confidently say that this person is cognitively unimpaired, or do I think this is subjective cognitive decline, or whether I have high confidence that this is something else. Or if you don't have high confidence, then you have to go further. So, is it mild cognitive impairment, where I may have some objective evidence along with some concerns, but they're essentially normal in their daily functioning, or is it a dementia level where impairment of functioning is occurring. And then the next step is to really define the syndrome, meaning what domains are involved. Is memory involved? Is behavior the major thing? Is it language function? And then the third step is to identify the most likely brain diseases or conditions causing this clinical syndrome, and any other conditions or factors that make sort of kind of contribute to this illness. And then it kind of goes through, what are the labs to order? What's the first tier labs? What imaging to order? How to put this together. So it's not, one thing doesn't determine what happens. It's really the integration of that together. And at each point, it suggests that if you are not confident, what else can you do? When should you refer to, for example, neuropsychological testing, or go to other tier tests, etc. Um, so bringing it kind of back to our patient, you mentioned that she had missed appointments and potentially medications. This is something that the son has also noticed, along with getting lost on the way. So I think there's a lot of right there. There's a lot of smoke. And then going through this process, we find that this woman has probably some apathy and withdrawal, and maybe some dysphoria, some depressive symptoms, but really not full-fledged clinical depression. And there's hearing loss. So both of those things have to be addressed, and they're risk factors, right? That if we remediate them and mitigate them, could actually help her brain status. But the standardized cognitive test that was done was a MoCA, and the score was 27 out of 30. And I'm interested to hear what you and Michelle think about a 27 out of 30.
Well, I mean, I think one thing with the MoCA is that it certainly does depend on education. And we did not talk about what the education level of this particular patient was.
That's right. That's right.
That's a great point. I mean, 27 out of 30 sounds fairly reassuring to me, but I have a feeling that you have a bit of a and but moment coming up.
I do have an and
Is
but
that right,
coming.
Ali? Okay, great.
That's right. So yeah, again, as you both of you pointed out, right, you have to put it in the context of the pattern of this person. So let's say they're college educated, right? And so you never just take one cutoff and say, oh, well, 27 is more than 26, therefore they're okay. You also want to think about how this fits in, the performance fits in with, I say, with the symptoms. And it turns out actually she missed all her points on memory recall. So she only got 2 out of 5 in memory recall, right? And when you gave her, cues, she didn't get it, but with multiple choice, she got one of them. So basically, if you fill out that, memory index, she got 7 out of 15, or 2 out of 5 recall. So that's worrisome, right? It aligns with the symptoms. And then some of the other things, the ADLs we went through, and she's essentially still independent. There's some variability, it takes her longer to do things. Occasionally there's some errors, or they're more effortful, but they're okay. And then there's what we call the tier one cognitive lab panel, which is a CBC, a Chem20 with LFTs, a thyroid, TSH, a B12, a homocysteine, an ESR, and a CRP. And it's casting a wide net for not things that are causing people to have dementia, but they can actually, they're common in older people, and they can point to other things that we can treat that can actually help their performance. And they were normal. And then the structural MRI comes back, and it says mild degree of generalized age-related atrophy and white matter changes.
Pretty standard. Pretty standard stuff.
Pretty standard. I have to say, for me, I always look at the MRI myself, because as I tell my colleagues, and we the subspecialists know, oftentimes a radiology read is a safety read of the MRI. And so they're really going to rule out, do they have a big tumor? Have they had hemorrhages? Have they had strokes? If so, how much? So a mild degree of generalized age related to an eye like myself may oftentimes, again, because I get a biased sample, I get the people who actually have memory problems or cognitive problems. Oftentimes, actually, the pattern is very different. There may be more, temporoparietal atrophy. There may be more hippocampal atrophy, things like that. But again, no big smoking gun as far as the labs and MRI about anything else. But certainly a lot of smoke here on the MoCA to me.
So would you recommend at this stage? I mean, so you do have a mocha, which which looks good and that initial result. I agree. That's a great point, bringing down the details. That there is more of a problem here. Would this be a patient for biomarker testing, or do you think you can go forward with, say, a diagnosis of MCI at this point without biomarkers?
Yeah, I mean, I think again, based on this, I would say there's some objective evidence here that goes along with the complaints. So it really depends on the proficiency and confidence of the clinician, how they feel about it, right? And at this point, would you want to do more? Do you want to potentially, because this is very early and mild, right? Do you have a good neuropsychologist you can refer them to? I mean, they're in their 70s. Medicare covers without prior auth a neuropsychological evaluation. I think that may be a really good way to go. Um, and then really it depends on how much more certainty do you want for the etiology of this, right? Certainly the hearing loss I think needs to be remedied. One needs to think a little bit about dysphoria, alcohol, bad medicines, as you mentioned, sleep apnea, all those other things. But this is worrying me. This would worry me that there may be that this looks like a amnestic MCI syndrome in a person who's in their 70s. And generally, with pretty high confidence, the vast majority of people like that end up having Alzheimer's neuropathological changes, at least in the brain. So if we do get biomarkers, we have to put that as part of, not as the standalone, but to integrate it in the clinical picture.
Yeah, those are really points well taken. I think from my perspective in primary care, oftentimes I will evaluate the patient, perform a screening test, and then send out for those for the laboratory testing, that tier one testing, send out for the MRI because there is a good amount of suspicion on my part too. But sometimes, but I also will, that's a good time to, hey, let's limit the alcohol, let's work on sleep. Maybe think about, this is more mild dysphoria, so I don't know about an antidepressant, but certainly hearing aids. And then you could recheck back in 6 to 8 weeks. I don't think you're losing a lot there. But if you notice the patient is remarkably better, because this has happened, especially with when it comes to hearing loss, then I don't necessarily continue down that path. I do keep in mind though that this is something I'm going to make sure I get this patient screened. Um, and so maybe though, for we have these different samples of biomarkers. They show up differently at different times in the disease course, and some of them are available in the blood. Some of them are really more exclusive to CSF or imaging studies. How do you differentiate which one is best for your patient, or can you?
Well, there's one of the other things that the Alzheimer's Association clinical practice guidelines does is actually, for the first time, incorporate a lot of these different biomarkers, and everything from when an FDG PET, for example, which is covered by Medicare, could be considered. When do you think about amyloid PET? When do you think about spinal fluid? When do you think about even genetic testing, for example? And uh, Understanding that I think probably many of those tests, like CSF, FDG PET, amyloid PET, right now they're still under the purview of specialists and probably subspecialists. Um, there's nuance in interpretation, and it's not 100%. And as you mentioned, there's temporal and other sequences that tell you something. So imaging, for example, some of the biofluids may actually become more abnormal early on than some of the imaging. Some of the imaging, for example, amyloid PET, really looks at well-formed fibrillar plaques in the brain, right? And uh, and tau PET is available clinically, but it's not widely covered yet, for example. So that's something that, for example, the CPG says, you know what, it eventually may go here. And the same thing with the blood biomarkers. They're available. They're not yet quite covered by FDA approved or covered by insurance. But that's something that really is going to be really important, I think, in primary care if used properly. And one of the main things about biomarkers is the diagnostic criteria for Alzheimer's disease have gone from the pathobiology, separating the pathobiology from the clinical syndrome, right? So the clinical syndrome can again be this spectrum of, cognitively unimpaired, subjective cognitive decline, MCI, mild dementia, moderate dementia, severe dementia, which is different from if you actually have amyloid positivity, which can be shown by different biomarkers at different times, or if you have a marker of tangles, of tau pathology. So that's called the ATNX criteria that just recently got updated, and also thinks of and puts in other criteria, the core criteria being amyloid and tau, but thinking about neurodegeneration, for example, that we can see on MRI, for example, or on an amyloid PET scan as being something that is non-specific, but affects the pathophysiology of Alzheimer's disease, or inflammatory changes, um, um, or vascular changes that we can see on MRI, or co-pathologies like, again, vascular and alpha-synuclein, like Lewy bodies, which we don't have great biomarkers for. We're starting to get something from spinal fluid, like a seeding assay or a punch biopsy, for example. But again, most of these are really they're highly evolving, and even for a biofluid like plasma, there are multiple different assays. And so this is something that is evolving, but really the blood is going to be an equalizer for access, and come to primary care, I think.
Hallelujah. I would say yes. I've been waiting for that for some time, because we do have these cases where we really want a little bit more information. All that great history, even advanced testing with neuropsychological testing, can still leave some things less clear. And when we're talking about such an important diagnosis, I want to make sure I have all the data possible. Michelle, what's your take? How do you think some of these biomarkers might be implemented overall when you look at the landscape from primary to specialist care?
Well, that's a good question, and that's something we're working on right now. I think the first step, as we have already talked about a little bit, is determining whether somebody has objective cognitive symptoms, and that's important for a couple reasons. One, because down the road, maybe the blood tests can be used like a cholesterol test, where you're trying to determine an individual's risk. However, at this point in time, we don't really know what a positive test means for somebody that doesn't have objective cognitive symptoms. They might develop symptoms down the road, or they might not. It's also important to note that for somebody that is not cognitively impaired or have cognitive symptoms, having a positive test result, which could happen because we know that pathology starts decades before clinical symptoms, but having a positive test result may cause consequences such as inability to get long term care insurance, life insurance, or disability insurance. So currently, there are no protections. Again, first aspect is to make sure there's objective cognitive testing, and then to look at, again, the whole patient picture. So as was mentioned, there was some mild depression, not a main concern. The person primarily had memory impairment as opposed to other domains. So this would be a person with high pretest probability of potentially having Alzheimer's disease, particularly since there is very little on the MRI. So then next question is, what blood biomarker tests do you use? And so right now, as Ali talked a little bit earlier, there are several different biomarkers that are available, and they are on several different platforms. And oftentimes in primary care, it really is dependent on what your institute or what your healthcare system or what labs they work with. For example, whether it's LabCorp or Quest or other types of labs as well, in terms of what you have access to. I do, right now, there are no FDA approved blood biomarker tests. So all current biomarker tests are considered in vitro diagnostic and are run at a single lab. Generally, for Alzheimer's disease, the main tests are the plasma amyloid beta 42/40 ratio, p-tau 181, or p-tau 217. If you had the choice between p-tau 217 and p-tau 181, p-tau 217 has been shown to be more accurate. Another possibility that is sometimes discussed in terms of blood biomarker testing is genetic testing for ApoE4 genotype. Now, from a diagnostic perspective, this is not necessarily going to help you determine a diagnosis because people will have Alzheimer's disease who do not have an E4 allele. However, this will become more important as you might be thinking about disease modifying therapies because monoclonal antibodies may have more side effects for those individuals that are ApoE4 positive.
Yeah, so carrying ApoE4, I think that's another one of those markers that can be problematic in terms of predicting risk and folks who get tested early, maybe they're only middle aged, but then they have trouble getting life insurance or long-term care insurance because of that carrier status. But now we're testing it more because we're thinking about using monoclonal antibodies and trying to judge their risk of amyloid-related imaging abnormalities or ARIA, which go up with the more copies of the ApoE4 allele that you happen to carry. So it's a little different paradigm now.
Yeah, and the CPG doesn't, recommend ApoE4 testing on the diagnostic side,
Right.
as Michelle
Yeah.
put it. Yeah.
Good point. So maybe, thinking about drug modifying or disease modifying therapy rather with monoclonal antibodies, these anti-amyloid antibodies, maybe you could talk about how biomarker testing might fit into that regime for maybe this patient, maybe our 73-year-old is actually, maybe heading towards one of the disease modifying therapies. How might we apply or not apply blood biomarkers in that case?
So, I mean, ultimately, again, this will depend on the healthcare system workflow, which is very important to consider. Primarily, right now, particularly in primary care, the blood biomarkers will most likely be used as triaging tools as compared to confirmatory diagnostics. And so, if we think about what the pathway might be, as we've talked about, there's a patient that comes in that has memory complaints. On the MOCA, they score 27 out of 30, for example, in the patient that we're just talking about. And there's memory concerns, but not really concerns in other cognitive domains. Blood testing appears to be normal in terms of rule-out labs, and there's a little bit of mild depression, but not a major concern. And so, given that workup and the concern about memory problems, then a blood biomarker and MRI might be helpful in terms of trying to understand what the etiology of that particular cognitive impairment is. Now, based on the results of the MRI and the blood test, for example, if the MRI comes back, there's not much atrophy, age-related atrophy, as we heard earlier. Maybe there's very little vascular pathology, but the blood test is positive. That provides further support that the person's symptoms may be due to Alzheimer's disease. And so this might be a time to refer the individual to specialty care, particularly if they might be interested in using monoclonal antibodies down the road as a potential treatment. And then once they get to specialty care, likely we'll have a CSF or amyloid PET confirmation. As we get further along and understand the blood biomarkers more in these patient populations, it is possible that the blood biomarker confirmation alone could be sufficient, but we're not quite at that point yet.
Yeah, that's a really interesting point because I think of the blood biomarkers and advantages. This is going to be done in a commercial lab. It's something many times a patient's going to be very familiar with it. I'm going to be more familiar with it as a PCP. But if we still need to go through PET scan or lumbar puncture, then that makes that extra step of getting the blood biomarker, especially when it can be really difficult to get it covered. And these tests are, my understanding for blood biomarkers is they're not inexpensive. Then maybe they're not quite ready at that stage yet if we're going to have to do a confirmatory test anyway. Am I wrong in that thinking, or what's your takes?
No, I completely agree with you on that front. And I think it's important to also point out the benefit of having a negative test. So, prior to these blood tests, there would be a memory concern referred to specialty care, but we know that there aren't enough specialists and there are very long wait times. And so coming back with a negative blood test, then maybe will allow primary care to focus on other aspects. Or, I mean, it's still possible that there's other dementias to think about, but it does provide very valuable information that might change that referral process to a specialist.
Well, it's very timely you're bringing up referral to a specialist because that's one of the things I wanted to have us all discuss together. Because my personal take is I actually really like to have just a co-pilot when it comes to managing folks with MCI or Alzheimer's disease, no matter what stage of the disease process they're in, because this is a long, quite serious disease that has a course where there's going to be different stages, and I might need different kinds of help. Maybe at the beginning, it's really more about reinforcing healthy lifestyles and other interventions that we can make, and maybe some symptomatic therapies as well, which I'm going to institute on my side as well. And the really exciting thing, and definitely not in my purview right now, is this possibility of using disease modifying therapy. That, but so I know that I'm not going to send patients to the infusion center myself. I know the kind of workup that has to go in and the shared decision making has to occur. That's really best done at a specialist level. But I also know that's a pretty limited time window, right? We can't wait months and months because patients may move right through that early stage of Alzheimer's disease into a more moderate stage where the monoclonal antibody isn't going to be applicable anymore. So really want to move things along as efficiently, but as carefully as possible. Some patients are really interested in these treatments. Some patients aren't at all interested. And of course, that is a huge factor. The availability of specialists is another big factor. We just simply do not have enough specialists in memory care. As our population is just growing older, and we're seeing a lot more patients developing Alzheimer's disease overall. So, and then finally, it's worth mentioning, and I think you were talking about this in using the framework for making the diagnosis of dementia. That while 60 to 80% of dementia in the U.S. is due to among adults is due to Alzheimer's disease, that means that 20%, 40% is not. And so there are some more complicated cases among younger people that could represent another process entirely. And I want to get help with those cases too. So I think that's overall my feelings on referral to specialists. But I think it's just good to have somebody to touch base with the patient, and maybe their supporters every 6 months or so is also, I think, a reasonable thing, because we're still in primary care managing the depression, the hypertension, the diabetes, the headache, all the health maintenance, etc. So, what's your take on that? That's my spiel.
Yeah, I agree. I think think about how much, if one goes through the primary care pathway, how much of that assessment already is done. So the patient would have a really nice history review of systems. They'd have their their MOCA or other standardized tests. Potentially, they may have neuropsychological evaluation as part of it. They'll have an MRI, maybe a blood test at that point. And so, first and maybe, multiple other tiers, selected tiers have already been done. And, one can put that in and package it and have it come to be co-managed between a specialist and primary care. But you're right. If the confidence is not low about the diagnosis, if you're thinking about these monoclonals, if it's rapidly progressive, atypical, young onset, I think those things from the beginning maybe should be fast tracked to a specialist.
Absolutely. I want you to function at the absolute top level. And I just, having had some conversation with patients about cerebral edema or cerebral hemorrhage associated with monoclonal antibodies, which is usually not symptomatic and not severe and something that can be recovered from. But just hearing those words, that's enough right there of subject material for a visit in and of itself. So I really and me as primary care, I don't necessarily know all the details about ARIA and the processes that patients are necessarily going to go through. But yeah, that way, the one thing I don't want either of you to be concerned with is, oh, they're missing an MRI, oh, a baseline MRI, they're missing their baseline blood testing as well. So yeah, but I do think that eventually, as was mentioned, when we have, I think, more of clarity on the accuracy of blood biomarkers, and we're still involving them with a complete assessment of the patient, I do hope that's something that moves in the primary care space. It seems like a natural to me. Other comments, please.
I agree. Yeah, I completely agree with that. And I know, Michelle's been working a lot on that and getting those kinks worked out, really, that allow these to be used by primary care with more confidence, I think, in a more diverse sort of medical population. I think we know comorbidities can affect results of some of the tests. Therefore, we're thinking ratios may be better. And I think Michelle used the word again that pre-test probability is really important. That pre-test probability you could only get based on a good workup and knowing that person and wrapping around and uh, yeah, yeah.
Yeah, there's still a lot of factors to consider in primary care. And there's been a lot of great work with these blood biomarkers, but not necessarily as much work among older adults that have multiple chronic conditions, cognitive impairment, polypharmacy. And so there's still work that we need to do to understand, exactly when blood biomarkers should be used, who they should be used for, and also, again, recognizing in older adults, yes, Alzheimer's disease is very common, but the older you get, the more additional co-pathologies you get, such as cerebrovascular disease and Lewy body and TDP-43 and other factors that you have to consider along with everything else. So I think that goes back again to some points that were discussed earlier that somebody comes in with cognitive or some cognitive concerns shouldn't base a diagnosis solely on the blood biomarker, but really have to take into the complete clinical symptoms, rule out blood tests, depression, a variety of other factors into the diagnosis.
And I would just summarize by saying it sounds like a lot, and it is, but this is so important. I mean, this is the diagnosis of a lifetime, and so you really want to be able to be there for patients and provide a holistic care as much as possible. I think it's really important to understand that framework that Ali describes so well, and so we really want to identify the problem, look at the domains affected, and then try our best to establish diagnosis. And that's the time we want to do the basic workup and do the outreach to specialists. And I think biomarkers are certainly a part of that. At that point, once you have the specialists involved, working the best of their abilities and primary care, I think it's okay. It's great to communicate on those subjects and decide, what's right for the right patients, keeping in mind that some of that biomarker testing can advance their care substantially, moving on to monoclonal antibody treatment and potentially disease modifying therapy, which is something we're so excited about when it comes to Alzheimer's disease. So, with that, Michelle, Ali, thanks so much for a great discussion. Really appreciate your viewpoints. Thank you to our audience as well for participating in this activity. Hopefully, you found it helpful to your practice. Please continue on now to answer the questions and complete the evaluation. Take care, everyone.